In this final part of the symposium, we're going to have a look at a number of non-odontogenic cysts in the maxillofacial region and other cyst-like lesions within the jaws. As the name implies, non-odontogenic cysts arise from epithelium other than that which has come from developing teeth. Two most common ones are the nasopalatine duct cyst and the nasolabial cyst, and they arise due to different abnormalities in the fusion of embryological processes. So we're going to go back a little bit to some embryology so that we can understand where these cysts come from. The nasopalatine duct cyst occurs in the midline of the anterior part of the palate, and the nasolabial cyst occurs in soft tissue of the face adjacent to the nose. So the nasopalatine duct cyst arises, as you would expect, within the nasopalatine duct or the nasopalatine canal. And here there are some epithelial residues which are left over from the nasopalatine duct, which is part of the embryological process of the developing palate. Now these cysts can be lined by a variety of epithelium, which could be respiratory type, which is more like the epithelium at the top end of the nasopalatine canal, and it's at the nose, or stratified squamous epithelium, which is more like at the oral end. Often we see both. So this is how this cyst develops. I'm going to take you back to some embryological development of the face, and you remember that the formation of the palate is quite complex, and it is resulting from the fusion of three different processes. These are the lateral palatine processes, which arise initially down the side of the tongue and then flip up to join together in the midline. But there is a part which is in the middle, which is the median palatine process, continuous with the philtrum of the nose and so on, but also bears the incisor teeth. And this median palatine process forms the premaxilla. And the point at which all three of these processes, that is the lateral palatine processes and that medial palatine process, meet is where the nasopalatine duct, the nasopalatine canal, forms. And initially, because it forms with the processes which are all epithelial covered, joining together, it is epithelial covered, and not all of the epithelium is removed when the processes fully fuse. And so there can be some remnants within the nasopalatine canal, which then are able to give rise to the nasopalatine cyst. So this is the appearance that you might see radiographically. As I indicated, it is in the midline of the anterior part of the maxilla, often centered around on the palatal aspect, the incisive papilla, because that is where the nasopalatine canal joins into the mouth. Here we have a well-defined, somewhat corticated, rather oval-looking radiolucency, and it tends to be situated above the root tips of the central incisors. Obviously, there is a differential diagnosis of a radicular cyst, and that needs to be taken into account. You may need to do sensibility testing and so on. And also in the radiograph, it's important to have a look and see if you can trace the periodontal ligament, the lamina dura, round the tip of the root. If you can, well then it's very unlikely that this radiolucency is involving the periapex of these teeth, and it may be completely separate, as it is in a nasopalatine duct canal cyst. The histology here shows something which is a really very early stage. And the neurovascular bundle, which is what normally runs in the nasopalatine canal, is present, but there is a small cyst developing from these epithelial remnants of the palatine processes. So here's another radiograph. Again, you can see it's the center part of the anterior maxilla, superimposed on a number of quite complex structures. Central incisors here, they look fine, and in fact you can trace the periodontal ligament space right around the apex of the teeth. So this is not looking like it's going to be a radicular cyst. Some of them can get really quite large. Here's one which is very evident on an OPT. It is relatively well defined again, but there is marked tilting of the teeth associated with that, as this cyst has now got to quite some appreciable size. And for the most part, clinically, where you will see the swelling from this is on the palatal aspect of the upper central incisors, although in many cases there may be no evidence of it at all. The histological features as I indicated earlier, there are a variety of different types of epithelium which line this cyst. In the picture you see here, this is a pseudostratified columnar epithelium with cilia, which is like the respiratory lining which lines the nasal cavity. And the following slide, which is here, shows an epithelium which is much more stratified squamous, but there are mucous cells, which the arrow is showing you here, which are mixed in with that, and again there are cilia on the surface. So very often the lining of the nasopalatine duct cyst is that mixture of respiratory type and squamous type epithelium. Another thing which we're looking for, just to confirm that in fact this has come from the nasopalatine canal, is in the wall of the cyst we very often find large nerve bundles or blood vessels in keeping with the neurovascular bundle, which is usually there. This is a cyst which is enucleated and then essentially does not recur. The nasolabial cyst, on the other hand, arises within soft tissue of the face. There are processes on the lateral part of the face, particularly on the lateral side of the nose, which fuse together to form the overall structure of the face. And again, there can be remnants of that which may form cysts. And in the case of a nasolabial cyst, it's in the nasolabial fold. It overlies the alveolus, it's not in bone, and it's at the base of the nostril, really quite deep into the nasolabial fold. And these processes which join together normally form the nasolacrimal duct, and so it's probably remnants or excess epithelium left over from that process. The lining is usually a pseudostratified columnar epithelium, that respiratory type of epithelium. And here we see an example, a lining here, which has got the keratinized epithelium and some underlying skin as well. A number of cyst-like lesions also present in the jaws. Some of them are apparently cystic but don't have an epithelial lining, and the best example of that is the solitary or simple bone cyst, which tends to occur in the posterior part of the mandible. The etiology of that is unknown. It is thought may be traumatic in origin, and at surgery it's a very strange finding of the cavity really seems to contain nothing, and there is a little bit of soft tissue, perhaps some blood on the outside and on the bone, but really no lining and no contents. And these tend to respond very well to curettage. Another curiosity is Stafne's bone cavity. Now this is not a cyst, but is really essentially an anatomical variant. You can see from the radiograph here why sometimes it would be mistaken for a cyst, because in the section of the OPT that you can see here, there is a well-defined corticated radiolucency at the angle of the mandible. In most cases, for a Stafne's bone cavity, it is deep to the inferior dental nerve, and you can see it's underneath that. It's not within the dental part of the alveolus. If you were to take a sectional radiograph, for example, in this CT, you will see that in fact it's really a bit of a false appearance in the OPT. And this is essentially a defect in the lingual side of the mandible, a depression, and it very often has salivary gland tissue in there. If you were, for example, to do a sialogram, you'd find salivary tissue extending into this area. So whilst it looks like a cyst on the OPT, in fact it's not, and it's just an excess amount of salivary gland sitting in a depression in the lingual side of the mandible. If you want to have a look at some further reading, Professor Spate, who is the previous professor in the department here, has a book, Cysts in the Oral Maxillofacial Regions, which you'll find in the library. And also there's some more reading on cysts in the Nusomes and Southam, chapter 6. Thank you very much for your attention, and I'm quite happy if you want to email me if you get any questions in relation to this, but for the BDS students, we'll hopefully be able to pick up some part of this in the lab class online in a little while.